academical manager for Jeffron, and along with Laila and Fanson from the marketing Jeffron, I'm hosting this webinar with the wonderful speakers from Asia Pacific. And as we know that one of the biggest challenge for the physician in casualty is that golden hour of the patient when you get in your hand, do the right treatment. And today, within this webinar, expert from India and Philippines, we will try to learn a lot from their experience of using HA230 Hemoadsorption cartridge for treating the patient in the golden hours, for detoxification, for poisoning, drug overdose, and snakebite-like situations. Before I invite the moderator, Dr. Kavita, let me give you a little introduction about our company, Jeffron Biomedical. So Jeffron is the global manufacturer for adsorption column. 1989, this company started and listed in stock exchange in 2016. In the year of 1999, first clinical use of Jeffron's macroporous resin based on hemoadsorption is used first time in the hospitals in China mainland. We do have 20 years of manufacturing experience and marketing and selling and helping a lot of people in the world with our technology. So far, around 92 countries, Jeffron have its products, and Jeffron has entered 13 countries in medical insurance, including Vietnam and other countries in Europe. We do have 5 production sites for dialyzer, hemoadsorption cartridge, consumables, machines, pharmaceutical products, and raw materials. We do have 3 research facilities and our headquarters in Zhuhai mainland. We do have CRRT machine, liver dialysis or ALSS machine, hemoperfusion machine, plasma filter, dialyzer, and various types of cartridges. So CE marked, MDA, GMB, all approved. And CA is our new product to the family. Up to now, around 290 international publication Jeffron has. And today's agenda, Assistant Professor Kavita Kumar from India will be giving the opening introduction and moderating the whole program. And Professor Sandhya Suresh from SRMC will be sharing her experience and basic of hemoadsorption technology in pesticide and drug overdose, followed by Dr. Cherry Grace from Philippines. And then we will have a discussion. All of you can type your questions in the chat box during the presentation. During the discussion, we will be addressing all of them. And it's my pleasure to introduce Dr. Kavita from Ramachandra Medical College and Research Institute for Chennai. She's the assistant professor in critical care medicine, and she facilitated and workshop many of the various national conferences in our country, in India. And she also an ABH coordinator for the ICU at SRMC. So, Dr. Kavita, please help us to moderate this webinar. And thank you very much for your kindness to take this job for us.
Am I audible? Good afternoon, everybody. First of all, let me thank Jeffron for inviting me to moderate this session. It's a pleasure to invite Dr. Sandhya because I work in day in, day out with her, and very budding and very enthusiastic nephrologist, I would say, who would always come up with new ideas of how we manage our problems in the ICU. So regarding paraquat poisoning, so this is when I had listened to a talk about paraquat poisoning, patients being saved by hemoperfusion, though there's not much evidence on it, is when I had a talk with Sandhya, and then we had started this work on it. So, and after that, though we have not had complete really great outcomes, but few patients have been saved. So let's kick on with introducing Sandhya. So Sandhya is an associate professor in the Department of Nephrology. She is also a recipient of a Young Nephrologist Award in the World Congress of Nephrology 2021. So she has done her undergraduation from Madras Medical College, post-graduation from CMC Vellore, and super specialty from am I correct, Sandhya, from Gujarat, right? I'm sorry, I forgot the
Yes.
name of the college.
Yes.
Yeah. So if we can start with the talk. Nice to hear Sandhya.
Are my slides visible?
Yes.
Yeah, your slides are visible. Yeah.
So at the outset, I'd like to thank Jaffron for inviting me for the talk. And also I'd like to thank Dr. Kavita for starting the whole discussion about hemoadsorption. This must have been about a couple of years back, I think, when we first had this discussion, and then we found out how to get the filter and how to start using it in our patients. So I will be, my broad outline of my talk will be mainly about our experience in our center with the HA230 filter, as well as the evidence behind its use in our setting of pesticide poisoning. So I'll be talking about the topic of hemoadsorption and acute intoxications. I'll start off with a case scenario. We had a 16-year-old child who presented to us in the ER about 7 hours after a deliberate self-harm event with paraquat poison. There was history of consumption of an unknown quantity of paraquat mixed with 200 ml of a carbonated drink. On admission, the blood pressure was 110/70 with a pulse rate of 106. She had the typical paraquat tongue, which is the mucosal ulcerations over the tongue that we see in patients who are consuming paraquat. Her systemic examination is otherwise normal at presentation. The urine sodium dithionate test was done immediately. So this was the urine sodium dithionate test. This was this dip is from the first time that we had done it. So it was pretty amazing that it suddenly turned blue. But we made a little bit of a mistake with the test here. Here we diluted the sodium dithionate as well. That's why it looks so dramatic that the urine turns blue after we added the sodium dithionate. So generally, the test is done by taking about 10 ml of urine, adding 5 ml of the 1 molar sodium hydroxide to alkalinize the urine. And then when we add sodium dithionate to it, it turns the paraquat in an alkaline medium into a blue tinged color. So this blue or a green color will denote the presence of paraquat and confirms the diagnosis of paraquat poisoning. So we were able to confirm the presence of paraquat in this patient's urine. And the child was promptly shifted to the pediatric ICU, and there was urgent insertion of a right IJV double lumen dialysis catheter. Within 1 hour, we were able to mobilize our team to start the hemoperfusion. This was about 8 hours post-consumption of the poison, and the hemoperfusion started with the HA230 filter. We did serial hemoperfusion till the urine sodium dithionate test came negative. Totally, we had done about 5 sessions over 3 days. So the first 3 sessions we did with a 6 hours gap, where we did the hemoperfusion. Then we would repeat the urine sodium dithionate test about 6 hours post consumption of post completion of the hemoperfusion. And if it was positive, we were again doing the hemoperfusion again with another filter. So this was how it was. This was the original urine sample, which was very blue. You can see that this is the nomogram that we have, the color coding for the the urine sodium dithionate test. It is a semi-quantitative test. The more blue it is, the more concentration of urine of paraquat in the urine. And as we did serial hemoperfusion, you can see that the blue tinge comes down. We have this slightly greenish thing, which is still positive. And then once we get the yellow color, it means that there is very low concentrations of paraquat in the urine. This child, over a period of time, she improved. There was an initial period where she required oxygen support, where there was a mild rise in creatinine up to 1.4 milligram per deciliter. Thereafter, over a period of 5 days, the child improved and she was discharged after 10 days of observation. So this was one of the first few cases that I had seen personally where where a patient survived after taking a significant amount of paraquat. So this we look into the background of poisoning that we see in our country. So what we see in our center is the deliberate self-harm. Most of these cases are due to suicide by pesticides, drugs, and any poisonous seeds. And there is a very high burden of pesticide poisoning all over the world. If you see in the Southeast Asian countries, there are about 300,000 suicides every year. This is the WHO data, of which 11.3% is due to pesticide poisoning. In India, it's a much higher percentage. More than 60% of population is in the rural areas. Many of them are involved in agriculture. And about 64% of poisoning patients are due to pesticides. And many of these are due to very toxic pesticides like organ phosphorus and paraquat and the yellow phosphorus compounds. Some of these have very high mortality rates, especially paraquat. So how do we get rid of these toxins? We have different blood purification techniques. We have hemodialysis, we have CRRT, we have plasma exchange. Now we have the hemoadsorption. So which of these would be ideal for the toxin that we are thinking of? So hemodialysis, we know it will remove the small water-soluble substances. So anything like methanol, ethylene glycol, lithium would get removed by hemodialysis. With CRRT, we can remove some of the middle molecules as well with the CVVH component. With plasma exchange, we can remove all kinds of toxics, but there are a lot of disadvantages in terms of hemodynamic stability, albumin loss, requirement for FFP with plasma exchange. Now we have the hemoadsorption. It can remove the protein-bound molecules as well, including the middle and large molecules. And mostly the hydrophobic molecules are removed by hemoadsorption. So we do have evidence to show that hemoadsorption can remove the pesticides, drugs, and biotoxins from the blood. So which extracorporeal technique do we choose in poisoning? It depends upon the dialyzability of a poison. It depends upon whether the poison is a small molecular weight or a large molecular weight poison, whether it has a large volume of distribution. Anything which has a large volume of distribution means that it's already left the plasma. Its plasma volumes are going to be only a small percentage of the overall toxin in the body. So just doing blood purification may not necessarily remove the toxin from other compartments. So in poisons with a large volume of distribution, the extracorporeal techniques may not be that effective. The solubility of the poison, whether it is a lipophilic or a hydrophilic molecule, the protein binding of a poison, the tissue binding of a poison. For example, paraquat goes and binds in the lung tissues. There are also the endogenous clearance with the kidney and the liver. We do know with paraquat that the initial endogenous clearance is very good from the renal clearance. In the initial, say, 4 to 6 hours. However, if there is significant toxicity and there is a decline in renal function, the clearance comes down. And also the half-life of the substance per se, and also our clinical experience with each of these extracorporeal techniques and the availability of the technique in each center. So generally, the rule of thumb is that any small molecular weight substance, which is hydrophilic, water-soluble substance with a low volume of distribution, we would prefer hemodialysis. Whereas if a substance is hydrophobic, which is lipophilic, or if it's protein bound, slightly middle to large molecular weight substances, where we would prefer the hemoperfusion. So in hemoperfusion would be preferred in paraquat poisoning, in organophosphorus poisoning. We do use it in other conditions like carbamazepine, digoxin, and methotrexate. There are several case reports of these in drug poisonings. And there have been instances of the hemoperfusion being used in snake venom, which I think Madam will be talking about in the next topic. And whereas dialyzable toxins would be the smaller molecular weight toxins like isoniazid, salicylate, citrulline, methanol, ethanol, ethylene glycol. All of these are more dialyzable, so we may not need to use a hemoperfusion cartridge in these cases. So how about the application of hemoperfusion in poisoning? It all started off with a charcoal filter. We don't use these charcoal filters right now because of the poor clearance of middle molecular weight toxins. They are very poor, biocompatibility. And there is a fear that they may break off and form embolism in the blood. So now we have the synthetic resins. So what we use in the HA230 filter is the double cross-linked styrene divinyl benzene copolymer, which is a synthetic resin. And it is more biocompatible. It is more flexible polymer, so there are more amount of pores for absorption. So I'll show you how it actually looks like. So if you see the filter per se, it looks like a box of chocolates, a small chocolate pellets which are distributed throughout a small filter, and it works. But when you look into these chocolate pellet looking these brown balls, you can see that on the electron microscope, it actually looks like a sieve. It's multiple sieve-like networks on a 3D structure. And even inside the sieves, you can see that this is where the blood flows. So the blood is not going to just flow on the surface of these brown balls of resin. It's also going to flow in between these pores of the sleeve. So this allows it to have a very high molecular surface area for absorption. So the surface area of this cartridge will be about 32,000 meters square. And it works on the principle of hydrophobicity. So anything which is hydrophobic would get absorbed without absorbing the blood and its components. So that is how the resin works. So the blood will go not just on the surface, but it will also go into the pores of the sleeve. And we generally connect it to the similar to how we connect the dialyzer. The arterial line goes to the blood pump, and then we attach the filter where usually we keep a dialyzer. It can even be done in series with the hemodialysis in case the patient also requires hemodialysis. Always remember that the hemoperfusion does not help in correcting the electrolyte imbalances or metabolic acidosis in these patients. So if these patients also have an indication for hemodialysis, we would have to use the filter in series with the hemodialysis. And the blood gets returned to the patient through the venous line. So where are the conditions that we will use the HA230 filter? We will be using it in pesticide poisoning like organophosphorus and paraquat. There have been some conditions where it has been used in rodenticide poisoning like tetramine. We don't have so much experience with other toxins, but most of our experience has been with paraquat poisoning. It has been used in snake envenomation, wasp stings, drug overdoses. We have had one case where we used it for an unknown drug overdose, and that patient responded well to the treatment. And there have also been cases where it has been used in other heavy metal poisonings. There's a case report of it being used in thallium toxicity as well. So this is the HA230 filter. We can see that it's got a priming volume of about 145 ml. Surface area, as I said, within the small box of 145 ml volume box, we have a surface area of 32,000 to 35,000 square meter for absorption, which is huge. And a little point about how to set up this filter, because it's important, because when we have a patient with poisoning, we are always fighting against time. When we have a paraquat poisoning, most of the studies have shown that we should start any hemoperfusion hemodialysis within 6 hours. So when a patient comes, we are running to the ER, trying to secure a line and trying to get this hemoperfusion started, trying to figure out the patient's financial burdens for all of this. Trying to figure out where to admit the patient. But in between all this, we also need to remember that this takes some time for the priming. We need to inject heparin 25,000 units into the cartridge and wait at least about 30 minutes. It has to be inverted 10 times, and it has to be laid on a horizontal surface for 30 minutes so that the heparin can absorb on the surface. Otherwise, we will be faced with the problem of clotting of the circuits. And it requires a priming volume of about 3,000 ml of normal saline. So that would take another 10 minutes. So this itself would take about 30 minutes of time consumption. So this is something that we should keep in mind and start the process as early as possible. How efficacious is the treatment? It depends on several factors. It depends on how early we are starting this. So the timing is the most important factor. Next is the blood flow rate. We need to usually keep a blood flow rate of about 300 ml per minute. And the treatment duration, usually the cartridge will last for about 4 to 6 hours. The frequency of sessions, which is what we have modified. So we do know that there are the problems of biocompatibility. The side effects that we can anticipate in these patients would be thrombocytopenia, which they can go in for anaphylactoid reactions and hypotension. So these are the things that we need to keep in mind when we start a patient on hemoperfusion. So now I will move on to a little bit of notes about the paraquat poisoning. So paraquat is a very toxic substance which is still being widely used as a pesticide in our country. It's been banned in a lot of countries. Unfortunately, it's a very cheaply available pesticide. So it is widely available everywhere all over India. And it's very toxic to humans and animals. And most of its toxicity is due to its accumulation in the alveolar cells in the lungs. And it causes lipid oxidation with free radical damage, and later on leads to multi-organ dysfunction involving the lung, liver, and the kidney. And it usually manifests with pulmonary hemorrhage, edema, lung fibrosis. Anybody who survives also has a risk of developing a lung fibrosis later on, and the patients can have acute kidney injury as well. If you look at the mortality rate in poisoning, in many of the Indian studies, if you see the mortality rate can be as high as 100%. In general, the mortality rate ranges anywhere from 70 to 100%. So a very highly toxic substance that many nephrologists have been crying out for years for it to be banned. Unfortunately, it's still available. Our center data, this was a study published in 2021, where we had 13 patients. Hemoperfusion was done in 4 out of these 13 patients. Unfortunately, there was a 69% mortality and 31% of patients went against medical advice, and all of these patients also succumbed to their illness ultimately. Hemodialysis was the only factor which was shown to have some benefit in this subgroup was the hemodialysis, which was associated with the lower odds of early death. So what hemodialysis was associated with was that it was associated with a delayed mortality. So that was the only thing that was the positive finding in the study. So what about hemoperfusion for paraquat poisoning? Most of the studies have shown that early hemoperfusion does help with paraquat poisoning. And this was a study from multiple centers. One of the first studies to show the effect of serial hemoperfusion, where they compared conservative group where there was no hemoperfusion. Then there was a hemoperfusion group where there were 2 sessions done on the first day, one on the second and one on the third day. So there were a total of 4 sessions, and each session lasting for 3 to 4 hours. Then the third group was hemoperfusion with the CRRT group. And if you see this group, although there was not a significant difference between the hemoperfusion with CRRT versus hemoperfusion alone, there was a significant difference in mortality between the conservative groups and the blood purification groups. So both the hemoperfusion arms showed better survival rates compared to the conservative arm, where there was a 40% survival only in the less than 40% survival in the conservative arm, whereas we were able to get about 45 to 50% survival in the hemoperfusion arms. So this was one of the first few studies to show the one of the large studies to show the efficacy of serial hemoperfusion. And this was a study which showed the benefit of early hemoperfusion within 6 hours. And here they found that early hemoperfusion within 6 hours, the mortality rate was only about 6%, whereas when the hemoperfusion started after 6 hours, the mortality rate was as high as 86%. It is a significant difference between the 2 groups. These are all retrospective studies. And this was an abstract which was presented in the ISINSA Critical Care Nephrology Conference. One of the first few studies to show the benefit of hemoperfusion done according to the urine diethynate test. So here in this study, they have done the urine diethynate test, and whenever it was strongly positive, they have done the hemoperfusion. And of these 15 patients, they found a mortality rate of 40%, which is significantly lower than most other studies which have been published so far. So most of the studies, as I've shown you, had a mortality rate of 70 to 100%. So 40% mortality rate is a significantly lower mortality. And many of these patients who presented late succumbed to death, and most of the patients who presented early within 4 hours were successfully managed. And this was the other study which showed the benefit of time-dependent hemoperfusion after acute paraquat poisoning. This was done from a university hospital in China between 2002 to 2012, where they had 621 patients. And we looked at that 6-month survival between those of these 621 patients. The overall survival was about 52%. And what were the factors which were independently associated with survival? Those factors were pulmonary lesions occurring after 8 days, and patients with a lower degree of urine sodium diethynate test, lower degree of positivity on the urine sodium diethynate test were associated with higher rates of survival. Another important factor which they found out in this study was hemoperfusion done first within 4 hours and the second hemoperfusion within 20 hours was also associated with a higher degree of survival. So we used this protocol done in this case report where they did serial hemoperfusion guided by urine sodium diethynate test. This was done from a hospital in Ludhiana in India. And this was a protocol that they had used where they did the first hemoperfusion within for about 4 hours as soon as the patient presented. And a second hemoperfusion was done on the next day and a third on the third day. So this was how the hemoperfusion was done in this patient. And they found a fading degree of urine sodium dithionate test positivity. And while this patient also had a rise in creatinine during the admission, overall the patient had a good outcome over a period of 1 week. And this is similar to what I had presented in our case report. So this is a protocol that we are following in our hospital. As soon as the patient comes with paraquat poisoning, the ER informs us in nephrology, and we have the urine sodium dithionate test kit. I would like to thank Jafron at this juncture for keeping the urine sodium dithionate, the sodium dithionate and the sodium hydroxide reagents available for us at all times. So, and we have primed our ER team to immediately inform in case of paraquat toxicity. So the urine is selected immediately and the test is done. In case of any doubt of the poison, many times we don't know what poison they would have consumed. So we assume it's paraquat and we check the urine sodium dithionate test. Immediately, if it's positive, immediately an IJV line is placed and a session of hemoperfusion is done. We repeat our test 6 hours later, and if it is still positive, then another hemoperfusion is done on the same day. And on the second and the third day, again we look at the urine paraquat test, and thereafter, if it is positive, we continue the hemoperfusion until it becomes negative. So generally, there is some thought that there may be some redistribution of the paraquat from the peripheral compartments into the blood between sessions. Usually, we give about 6 to 8 hours for this redistribution to occur. And as per the state guidelines in our state of Tamil Nadu in India, we have also given steroids and cyclophosphamide for these patients. And as per the guideline, it is methylprednisolone of 30 milligram per kg, followed by 5 milligram per kg for 3 days. And then we also give cyclophosphamide IV. With our center, what is the data that we have so far? We are yet to analyze the data completely, but so far we had about 8 patients where we've done the serial hemoperfusion. We usually required a median of about 3 to 4 sessions of hemoperfusion for every patient. And we initiated this with all patients with a positive urine sodium dithionate test, irrespective of the time of presentation or the quantity of paraquat consumed. And we had 2 patients who survived with this, giving us a mortality rate of about 75%. But before all this, before we say that this approach has reduced our, has improved our survival to a small extent, I'd also like to point out the problem with this approach. So you can see that this is how paraquat leaves the body. So this is the concentration of paraquat in the blood. This is the straight black line. The red line is the lung concentration of paraquat, and the dashed line is the concentration of paraquat in the tissue. Even if we do nothing, we can see that the levels of paraquat in the blood does come down over the first 6 hours. And it's because of very good renal clearance of the toxins in the initial 4 to 6 hours, whereas the tissue levels and the lung levels hardly remain changed. Whereas when we do the hemoperfusion early, there is, to some extent, there is some degree of reduction in the tissue levels as well as the lung levels, but it never comes down to zero like how the blood levels come down. So we can see that even though the blood levels of paraquat comes down to zero, the tissue levels and the blood levels are still pretty high. Whereas if we do late, the gray zone is the hemoperfusion. So if we do hemoperfusion later after 6 hours, the degree of reduction of the paraquat in the tissue will be even less. So there is some benefit in doing it early, but doing late hemoperfusion really it may help in reducing the blood levels of paraquat, and so the urine sodium dithionate test does come for negative, but the tissue levels of the toxin is still unchanged. So that's why even though we have done serial hemoperfusions, a lot of patients have still succumbed to their illness. So mainly the things that we need to remember is that there is limited benefit after the first 6 hours, first 6 to 12 hours. It's the same thing in animal models as well. And there is minimal effect on the lung uptake, and hemoperfusion started after about 2 to 4 hours does not reduce the lung paraquat levels significantly. There is going to be a redistribution from the tissues, which is one reason why we do say that a repeat hemoperfusion session after a period of 6 to 8 hours may help in removing the paraquat that redistributes from the tissue. But at the same time, plasma removal does not mean that it's been removed from the tissues. Many studies have not shown a survival benefit from hemoperfusion, repeated episodes of hemoperfusion, even though some studies have shown an increase in the survival duration. And still the overall fatality rate is very high. It's still more than 50%, even in centers routinely using this hemoperfusion and hemodialysis. And it is almost similar to those not utilizing these modalities. So these are some things that we need to keep in mind when we are thinking of this approach. To sum up, the HA230 is a filter which will help in accelerating the elimination of poisons and reduce these substances from the blood. It can help in reducing the complications and improve the overall survival and the survival duration as well. And they can be used for a wide range of toxins, predominantly the protein-bound toxins, which are like lipophilic as well. And it can help in removal of the pesticides, herbicides, and rodenticides with drug overdoses and in certain heavy metal toxins as well. The important things to keep in mind is that it should be started as early as possible. We may require multiple sessions of hemoperfusion at the beginning, and it has to be done more than once a day in the initial period of presentation. Thank you.
Thank you, Sandhya. Hi, it's glad to introduce Dr. Cherry Grace. She's from Philippines and she's a consultant toxicologist and clinical epidemiologist. This was quite an interesting thing for me to see that when she has done a lot of work on snake bite poisoning, which is a very important poisoning that we also encounter. She is somebody who has received multiple awards for research and clinical case studies in toxicology and emergency medicine. Over to you, ma'am. We are looking forward to your talk.
Thank you, Victor, for the kind introduction. Thank you so much. Let me first share my slides. See my slides?
Yes, ma'am. We can see
Okay.
it.
So I the first lecturer, Dr. Sandhya, has actually mentioned a lot of the basis why we use hemoadsorption and what is its possible roles in critical intoxication. So to start, these are my disclosures. So my focus actually is more on the hemoadsorption for snake bite envenoming. As it was already discussed earlier, I will not focus on drug intoxication. I will also, as you can see, there are a lot of research gaps. So I will also show the research gap so that we can encourage see and explore the roles of hemoabsorption in our practice. I believe majority in the meeting room are nephrologists and toxicologists. So I also hope that we can also come into challenge to right and to have consensus in the use of extracorporeal treatment, especially hemoabsorption with additional interventions such as hemodialysis. So I will also provide our clinical experience why in our locality, we have opted for hemoabsorption or hemoperfusion, specifically for hematologic snake bite envenoming. So I think all of us, majority are from India and Southeast Asia. So we all know that this is very common. And in our WHO has reported that around 70% of the annual global snake bites are actually in South Asia and Southeast Asia alone. Our problem here in the Philippines, unlike our neighboring countries such as Thailand and India, is that we only have one antivenom that is manufactured in our country. So that is actually remains a problem despite increasing number of reports for snake bite envenoming.
Ma'am, just a minute, ma'am. I think your
Yes.
voice is breaking. So can you
Okay.
just ensure that the voice is more clearer?
Okay. So, is it better now?
No, ma'am.
Okay. So we all know that usually in snake bites there is a multi-organ failure. It's very much common, specifically neurologic and hematologic. In most of our cases seen in our center, they go into systemic inflammatory response syndrome. And before they go to multi-organ syndrome. So this is also the reason why we have actually later in our case report, we have opted a combination of hemoperfusion plus dialysis in these cases that we have documented. So the common approach for snakebite envenoming is that still anti-venom is the primary treatment. So, however, and then the focus is history, diagnostics such as laboratory tests. However, it is more, especially in our country, we're underreporting and studies are not are usually not very common, especially on snake bites. We go into more on clinical diagnosis. So the focus in first world countries is that the use of anti-venom first, and also supportive therapy such as blood product transfusion. In most of the guidelines, you can see that hemoperfusion is not recommended, and even the timing for when should hemoperfusion is possible for snake bite envenoming is also not yet well documented. So for in our case, usually we use clinical severity score to guide us whether to start or treatment and intervention. So usually with because there is lack of anti-venom, and because as mentioned earlier in the first lecture, there is a role of hemoperfusion for snakebite envenoming, especially when it presents with advanced multi-organ failure, as well as when it comes in early. I think one of the question in the chat box is when to start early hemoperfusion, or when can you start, what is the golden period for hemoperfusion? So as toxicologists, we, as much as possible, we don't want absorption of the toxin. So in the protocol for snake bites, especially for hematologic poisoning, is still in Philippines, we are still developing it. But on the 5 or more cases that we have handled, our cut-off for the golden period is around 5 to 6 hours. So one thing also that we are looking out and also is the venom-induced consumption coagulopathy, as well as thrombotic microangiopathy. This still is actually, this cannot be addressed by hemoperfusion. So we still use supportive therapy for this. As you can see, our available interventions for extracorporeal treatment is the use of hemodialysis for acute kidney injury. So for hematologic envenomation, usually we have more cases presenting with acute kidney injury as well as coagulopathy. So this is the reason why we usually combine hemodialysis and hemoperfusion specific for snake bites. So although plasmapheresis has not been explored, there are small studies later on that I will show that this actually supports possible intervention for hematologic envenoming. So these are, as mentioned, the research gaps in our main consideration, why we are acknowledging that there are very small studies. So when you're doing clinical practice guidelines and consensus, usually the usual conclusion is that there is less evidence supporting hemoperfusion. So actually that is our goal and one of our innovations that we want to start to at least record our experiences so that we can formulate our our consent to develop a consensus or a clinical pathway specific in our country. So the question is that the only antivenom that is available in our country is for Philippine cobra, which is Naja philippinensis. This actually presents with neurologic envenomation toxicity, and our next challenge is that mapping of the local species variation is not yet and also the supporting publications for this local species variation is actually is very limited in literature. However, we have ongoing collaboration with toxinologists, which is also a growing specialty in our country. So I am from Negros Occidental, which is actually in the center part of the Philippines. This is one of the drivers why we have opted, aside from the lack of envenoming, we have opted for the possible use of hemoperfusion, since majority of actual reported cases and published studies are on the use of hemoperfusion is more on neurologic effects, reversal of neurologic effects for of snake bite and venom. So, however, unique in our geography, in our location, for the two islands, for Negros Occidental, for Negros and Panay, majority of the 38 species that were actually mapped in the region is actually more of vipers, especially Trimecerus flavomaculatus. There are also signs of colobridea, which are actually more of hematologic. So even if Naja philippinensis is present or it's actually manufactured in the country, this is actually we cannot utilize it for our snake bite envenoming. So when we have encountered this is actually there were increasing cases, especially that there are active volcanoes that were active for the last since 2024. So that's why we have explored hemoperfusion, particularly on snake bites. So as you can see, the majority of the evidence is that supports these are only more on based on animal studies, and that they are more on critical for neurotoxicity from snake bites. So what are other considerations? So one consideration is plasmapheresis. However, usually this is not usually done because also of few supportive evidence for and that it is usually more evident for drug intoxication. So for hemoperfusion, although there are rare reports in the context of hematologic complications, we have focused on possible applicability since there are no other treatment modality that we can offer to the patients. So as you can see, specific for snake bites, majority are for hemoperfusion. Actually, the studies are more on animal studies and usually non-hematologic use. So we would like to present some of our first two cases that we have actually presented. Currently, we have around 8 cases that we are monitoring serially. So still, we acknowledge that the mainstay of treatment is an antivenom as well as supportive care. However, for severe and refractory cases, ECTR can still be used. This is actually what we have presented, presenting 2 cases of pit viper envenoming. So actually, the patient presented late at day 2 of injury. Patient has already presented with although clinically stable in the emergency department, there was actually rapid based on clinical symptomatology. Invaluation was already severe. The three patients were actually advised for for possible IND as well as possible amputation. However, we have initiated with on the day 2. So this is less than 24 hours within 48 hours of injury, even with presenting with coagulation abnormalities and also presenting with API. Patients and also patient had only limited number of sessions of hemoperfusion plus hemodialysis. So they only have 3 sessions. However, as you can see, these cases actually, despite the progression, the severe cases, they were all discharged on day 5 and 6 with resolution of symptoms. So the case actually is the most severe case in which he has already presented with compartment syndrome and already has progression of multi-organ failure. However, this was reversed after 3 sessions of ECPR. As you can see with the number of sessions, there is also limited, the only supportive treatment that we have provided was only transfusion of platelet transfusion. So this is my last slide. So our conclusion is that supportive care because of the absence of antivenin is still is very important, and that we have growing cases to support that hemoperfusion or hemoadsorption can actually provide support for the clinical intervention for hematologic poisoning. However, and also to have a life-saving potential early initiation, which is actually within 6 hours, 5 to 6 hours of treatment, has shown a shorter hospital stay and also less severe coagulopathy or decrease in platelet during the course of the admission. So we are actually hoping that with these talks we can encourage more cases and studies to be published so that we can create our consensus, especially locally or within the region. So thank you very much.
Dr. Kavita, thank you.
Yeah, can we go ahead with the questions?
Yes.
Yeah, so first are the few questions for Sandhya. What many of them were asking about the filter. I think she's answered already in the chat box about where the cartridge should be placed. Am I right, Sandhya? You've
Yes,
answered
yes,
to them about.
yes.
So there are a few other questions which was interesting was, can we use this filter along with the ECMO or the CRRT circuit?
Yes, we can use it with the CRRT as well, ma'am. I am not sure about the connections with the ECMO, but we can always run it with another dialysis machine separately. And
Okay.
with CRRT, we can just connect it in series with the CRRT filter. But we need to remember that the hemoperfusion cartridge can be kept only for about 4 to 6 hours maximum. So after that, that has to be removed or it has to be changed, and the CRRT can continue after that.
Okay. Because why I asked about ECMO is because there are few hospitals which have offered for paraquat poisoning. ECMO is also as an option. See, because the lung is the main organ which gets affected by the paracut. So when patients have, like we have, though we haven't done, like in some hospitals they do offer. So maybe we need to know about that too later on if we can find out. The other question which was asked about is how do you gap between the sessions? Like how do you decide between when you do the first session and the next session when you would be doing it?
So this has been mostly arbitrary based on whatever studies that we have gone through and what they have done in that study. This was based on that one major study where they did the hemoperfusion twice on the first day, and then they did it every day for the next 2 days. So that was what we mainly based it on. So we do about 2 sessions in the first day with a gap of about 6 to 8 hours, which we believe will help in the redistribution of the rebound of the paraquat from the peripheral tissues to the blood. So this is just mostly based on whatever studies have been done so far, but there is no absolute data on this, and we unfortunately don't have the plasma paraquat levels available as of now. We are using the urine sodium diethylate test only to see the presence of paraquat in the blood.
Any other poisoning or anything which can show falsely a blue color, or is it only paraquat that we have?
I am not aware of whether anything can cause a false positivity here.
Fine. This one thing which was interesting for me was that about priming time that you told me that the priming takes 30 minutes, because from whatever evidence
No,
that we have,
priming would take
that
about 10 minutes, ma'am. 10 minutes.
10 minutes.
The
Okay.
problem is
Okay.
the heparin coating. The heparin adsorption would take about 30 minutes, but usually we start off the priming in about 20 minutes. So the overall timing, it's about 30 minutes.
Yeah, so that means if I have to start a hemoperfusion for a patient of paraquat poisoning, because already see whatever evidence we have is when it has been started as early as within 4 hours. So first patients reach in very late for us. So if we decide on hemoperfusion, maybe simultaneously somebody has to put the line and simultaneously start on the priming, and logistically wise, I was just thinking maybe maybe do the hemoperfusion in the emergency room rather than shift on to the ICU to wait, because again that shifting is going to take a time. So maybe I think we can save at least 2 hours in that, so that we can cut down the time of early initiation of the hemoperfusion, which is what practically I felt maybe that could be done. And one more question which was asked was about the gap between the sessions and how do you check for the adequacy of your session? Like
there is actually, it's not the hemoperfusion. It's not possible to check the adequacy like how we check with dialysis. We have the urine sodium diethionate test, which is only a semi-quantitative test. Ideally, we should be doing the blood paraquat levels. But again, studies have shown that the blood paraquat levels do not really reflect the tissue distribution of the poison, and they don't have that much association with the mortality as well. So we are just going with a fixed protocol as of now, and seeing how the outcomes are based on the existing evidence.
So total sessions that you will be doing for every patient would be how many sessions?
Around 3 to 4.
3 to 4. So
After that, if there is there is going to be progression of multi-organ dysfunction, usually there is more sessions are likely to be futile in those settings. So then we would just do hemodialysis according to the patient's own indications.
Okay, thank you. So I think I would like to sum it up in paraquat poisoning saying is early initiation makes a big difference. That is within 4 hours, within 2 hours best, or at least within 4 hours. And maybe as logistically wise, when you do it in the emergency room, in the place of your receiving place, where simultaneously line is placed and the priming has been done, so that you save the time. Another thing is once they have others like plus other very important take home message, which I think Sandhya very clearly put, plasma removal does not mean it has been removed from the tissue. And whatever is bound in the tissue is the one which causes a lot of problems. So that's why early initiation is the key. I think the key to make a difference in the mortality would be to initiate as early as possible and see where all we can cut down on the time. And most important is probably ban the weedy side.
Yes.
Yes.
Any other questions, Mani, for Dr. Sandhya? This is what I had got. Any other thing that you had got?
No, I think perfect. Since we have another 4 more minutes, you can go to the question to the
Yeah.
second speaker, Cherry Grace, doctor.
Yeah. Ma'am, regarding for you, it was very interesting to know that we can use hemoperfusion. But my only question is it used only for patients with hemotoxic snake venom, or is it used also for neurotoxic snake venom patients?
There
Was one of the
there are
questions.
hello. There are actually uh, uh, reports on neurologic patients with neurologic presentation with snake bites with neurologic presentations, but we have not experienced that in our center.
Ma'am, you're not clear. I didn't get. Is it useful for neurotoxic snake venom patients also?
Reports actually are for neurologic presentation. There are actually publication for neurologic for envenomation with neurologic presentation rather than hematologic presentation.
Okay. And ma'am, as you said about when you do not have an anti-venom present, like because there are many species. So I came across
Yes.
something very interesting. In Australia, what they do have is like when even in India, the anti-venom that we have, it is not specific for. We have the common species which they have taken, and we have the anti-venom which has been made. So that is why there are chances that many a times your anti-venom may not, if it is a species of snake where which you do not have the anti-venom in specific, then it might cause problem. That is your anti-venom
Yes.
might not work. So that is the basis that you're saying that though anti-venom is the treatment format for snake bite poisoning, places where you do not know that there are a lot of species, for such patients, probably you're saying hemoperfusion might work, and for hemotoxic snake venom. Am I right, ma'am?
Yes, it is.
Okay.
Because it should be species specific when you give the anti-venom.
Okay. Okay, ma'am. And can it be used alone or along with antivenom was one of the questions. And I think you've already answered whether it is here. They have one more question which was asked was whether hemoperfusion was useful over antivenom. So you very clearly said that this is just in the process of study. Evidence basis only for mainly for the antivenom. And if we have species specific, maybe it will make a huge difference in the outcome. So when we don't have that, that's where we are trying to bridge with the hemoadsorption.
Yes.
Am I right?
Yes.
Okay. Ma'am, and how do you identify, like there are so many, you gave the list of snake species that are available in your place. So when a patient comes with a snake bite, if you know and if they have taken a picture of the snake, fine, well enough. Suppose you have an antivenom and it's going to be useful, how do you decide which one to use then?
Actually, there's only one antivenom produced in our country, which is
Okay.
actually for Naja, which is also not present in our locality. So we
Okay.
cannot use that.
Okay. Oh, fine. One of the other questions which were asked was, is it useful for other poisonings also? They wanted to know about like OPC poisoning and all can be used.
For hemoperfusion, actually we
Yeah.
have experience also. I also would like to add that in our, especially for drug intoxication, so there are specific drugs, I think mentioned by Sandaya, that there are specific medical drug intoxication in which hemoperfusion can be used. The frequency actually we use is based on the half-life of the drug. So that will actually guide us on the number of the sessions. These are actually, so we can either use 1 to 2 sessions alone with hemoperfusion only for drug intoxication. So majority of our experiences are those for antihypertensive medications, calcium channel blockers, such as amlodipine. We also have experience with carbamazepine.
Okay. Okay. So any other questions? There's no other questions, ma'am. So I think to sum up in terms for snake bite poisoning, if we do not have a specific anti-snake venom available in our place, maybe hemoperfusion can be used as a supportive along with the anti-snake venom. Am I clear, ma'am? Anything else, ma'am? Can you give your final comments on for your part of the presentation? Anything that you would like people to just take home as a message?
I think early no, even if we cannot recognize the snake, still we can go use clinical assessment, and also we encourage early initiation of hemoperfusion for especially for intoxication cases or poisoning, so that will give you a golden period of around 5 to 6 hours to improve outcomes.
And how often do you do the sessions, ma'am, for your patients?
So usually it depends on what is the agent. So usually with drug agents, usually guided with the half-life of the drug. So usually it is we either do it around twice in a day. But however, with snake bites, we usually do it every 6 to 8 hours, lasting for around 4 hours.
Okay, okay. And when do you decide to stop, ma'am, your sessions? Like when do you think
because we are not unlike drug intoxications in which we can be guided with drug levels, blood levels. We usually go clinical when there is actually resolution of symptoms.
Okay, okay. Okay, ma'am. Thank you. Sandhya, your final comments on hemoperfusion on paraquat poisoning?
I think as ma'am, you already had told that we need to use it early and maybe some multiple sessions. We'll have to do further studies. We'll have to do ideally do the blood paraquat level, see if we can get a some way to easily get a tissue paraquat level. And we need more evidence. We need a lot more evidence on this poison as well as on the filtration techniques for this poison. And we also need to see whether there are any other indications that we can expand it for, like as Mohammed already told about the drug overdoses. We did use it for a patient with an unknown drug overdose, and we need to see what all conditions where it may be more beneficial than hemodialysis. So these things are some things that we will probably learn down the line.
Thank you.
Thank you, Sandhya.
Thank you, Kavita.
so-
I think
Yeah.
we conclude.
Yeah, you can
Thank you
conclude.
very much, Dr. Kavita, for this wonderful discussion, which is really very well. You three are done it well, especially explain about the point about the golden hours, how to make it useful, especially Dr. Cherry Grace and Dr. Sandhya's was experience in their paraquat and other poisoning. Of course, we're looking forward more experience in organophosphate and other poisoning, drug dosing, drug poisoning, etc. Our apologies that if we miss any of the question from the chat box, we'll be looking into that and adding about the golden hours. And I remember, ma'am, Ma'am was telling about the 30 minutes is priming quite more time, especially 10 minutes only priming, 30 minutes for the heparinization. As per our IFU is 10 to 30 minutes. So if it's emergency, you don't need to go for 30 minutes, minimum 10 minutes, maximum 30 minutes. So I think we give you 20 minutes extra to save a golden hours. Thank you very much, all of you. And all of you join this webinar. Thank you very much for wonderful questions. And please give us your valuable feedbacks. And next webinar we'll be hosting soon, which is clinical experience and evidence in hemoadsorption and cardiac surgery. Please tune into that. And also we will be there in Germany on 28th ESICM Congress. Those who are attending there, please remember to meet our booth. Thank you very much by behalf of Jeffron and Laila and Hela. I mean, everyone, we are saying goodbye now. Thank you very much.
Thank you. Thank you.